Good evening, ladies and gentlemen, dear colleagues. Welcome to the Starlink webinar, Medical on Air 2024. Today, we are going to talk about the CSU toward remission. I'm very happy to see Dr. Kochatuk again, and today her topic will be breaking down barriers for CSU management. And we know that she is a world-renowned expert in urticaria management. She is currently the professor of dermatology at Department of Dermatology and Koç University School of Medicine in Istanbul, Turkey, and also a researcher in the Institute of Allergology of Shahite University in Berlin, Germany. She is a board member of the Urticaria Network, UNEV, and also the secretary of Dermatology Allergy Task Force of Turkish Dermatological Society, and also members of the EADV, EAACI, and ESCD. She has many publications, including some treatment guidelines of urticaria, urticaria in pregnancy and lactation, and COVID-19 and urticaria. So she has published more than 150 publications in many world prestigious journals, including Allergy, JACI, and JEADV. Today, the topic will be breaking down barriers for chronic spontaneous urticaria. Before her talk, I want to ask you all a question. What is your treatment goal for urticaria treatment? There are two answers. The first one is remission, and the second one is symptom control. So let's start to vote. Only three votes. How many? Three, only three. Only three responses. Hurry up, we have a 50 versus 50. Yeah, I think it's a philosophic question, remission or symptom control. The question is that, are patients able to achieve remission? Do you think so?
Yes, I believe urticaria has a remission, spontaneous remission. But the question is, when does it happen, I guess?
Yes.
Yes, so first of all, I'd like to thank you for your kind introduction, Professor Chu. I'm so happy to be speaking with you here about urticaria, which is our favorite disease to treat and help the patients. So I would like to mention, first of all, there is a debate on the definition of remission.
Yeah.
Is it happening in 1 week, 2 weeks? 6 months, we don't know. So there is a debate. Some studies say that it is the absence of urticaria for at least 4 weeks without medication, while others say that 3 months needed to say it. Others say that 6 months is needed, while some studies say that it should be 1 year without treatment, while the Spanish urticaria experts propose that it can be 2 weeks with standard dose antihistamines and 4 weeks with up-dose H1 antihistamines and 3 to 6 months when we use biological treatment. So what do you think? Which one do you pick?
It's difficult. I think every answer have their own reason and quite reasonable. But my personal view, my philosophy, I prefer the right one, the absence of urticaria treatments from any medical services for at least 1 year.
1 year.
Yeah, but it's difficult for patients to accept that. So in my clinical practice, sometimes I just compromise myself. I tell the patients, you must reach the first goal is to have the absence of hives and angioedema in at least 3 months. That's the left side. So theoretically and realistic, I have different mindset for the patients.
Yes, of course. So you start stepping down after 3 months of
Free of symptoms.
Free of symptoms,
Yeah.
yes. And you call the patients that they got into remission after 1 year of without treatment.
Yes,
I
exactly.
agree with you.
Yeah, yeah.
So maybe we can have a look at the published data. Now there is a nice systematic analysis review that shows that only 17% of the patients get into remission in 1 year, while 45% get into remission in 5 years, and in 20 years, 73% of the patients get into remission. So that means that 17% of the patients still have urticaria after 20 years. So what can we say? We can say that half of them will be free of urticaria in 5 years.
Yes.
But it may take some time for the others, but the few ones we can say.
Yes.
So, but who will take longer to get into remission? Maybe we can search the literature for this information, and what we found is from Israel, they showed that when urticaria starts with a severe disease, with angioedema, and when the patient has these autoimmune features like autologous serum skin test positivity, plasma skin test positivity, or a presence of antinuclear antibodies, then they may have a longer CSU duration and the remission may take longer. And also presence of systemic hypertension was associated with longer CSU duration. And from Korea, Kim and friends reported that patient age over 65 years and female patients were likely to enter remission than male patients. So these are the findings, but I think you would also agree that autoimmune patients would last longer than the other ones.
Exactly. I agree with the first one, the Israel study showing that ASHT or the presence of some autoantibodies, those patients are more refractory.
Yes, I agree. Refractory and takes longer time. And I would like to also mention our data from a UCARE project. So we had 2,554 chronic urticaria patients, and almost 20% of them had a chronic urticaria with more than 10 years duration. So it's a long percentage from my point of view. It was really taking too long in these patients. And when we compare the patients who were taking shorter than 10 years, we saw that these patients with longer disease duration were often female, had a BMI over 30 kilogram per square, and CSU without CIndU. They also had wheals plus angioedema. When they are together, it shows a refractory and chronic course. And more often, these patients had comorbid systemic diseases like thyroid disease and hypertension. More often, they were associated with allergies, and they had higher total IgE levels. So I think a bit atopic and autoimmune, and when there is systemic inflammation, the disease tends to last longer. And this BMI is always coming in our tables as I think it creates systemic inflammation and makes the diseases last longer.
Yes.
So I think a good lifestyle is also important. Maybe we should also emphasize this for our patients. Okay, so the guidelines suggest that we should aim complete disease control.
Yes.
Although our colleagues could not decide between remission or complete disease control, but they were both right, because the guidelines suggest that we should aim complete disease control until remission. So we are aiming both for our patients, and we should treat the disease until it is gone.
Yeah.
So it's not a 2 months treatment, it's a treatment that should last until the disease is gone.
So the problem is that if remission can be achieved, then what will you aim for? There are many potential philosophies for the physician and patients, But I would say from the previous analysis, we know this is a curable disease. It can be remission, can achieve remission, although it may take longer than patients or physicians thought. So there are two potential aims for those cannot achieve remission. So the first answer would be complete symptom control. You just treat the symptom, let the symptom completely controlled. The second one is to normalize the quality of life of the patients. So now we can vote for the second question. Only 50-50. Always 50-50.
That's nice.
That means usually, that's like our society.
Yes, there's always a debate on everything.
Debates,
so, but this makes science progress,
Yeah. And during your vote, please think about the philosophy and what is your practice to reflect your idea and the concept of the disease treatment. Okay, so move to the next one. So what's the realistic goal towards this remission? How do you think about that?
Yes. So as I mentioned, complete control is the suggested treatment goal by the guidelines. But is it achievable? Maybe we can look at the omalizumab clinical trials results, and then we see that well-controlled urticaria, which is shown by UAS7 score smaller than 6, it was achieved in Asteria studies by almost 60% of the patients, and in glacial almost 50% of the patients, while the complete control was achievable by 40% and 33.7% of the patients. So it seems that complete control is not that easy. So, but if we have complete control, if we give our patients complete control, then the studies show that they have a better quality of life, they have a better sleep, they are doing better in their work life, and they are feeling complete, they will have a complete well-being if we provide them complete control. But complete control takes time, and maybe we should tell our patients that it may take almost 2 years to achieve complete control. So that means that we should never give up, the patients should never give up, and continue treatment and keeping with us, trusting their doctor that the complete control will come, or at least if it doesn't come. So what the patients want, the patient wants reduction of itch and burning and resolution of hives and wheals. And so the patients who has better urticaria control, better treatment satisfaction, and when they perceive that they can trust their physicians, then they have better treatment satisfaction. And beyond this, the patients are expecting a better quality of life. So I think the most important point is the quality of life. Even patients can have a few wheals, but if they are feeling very well, that they feel completely controlled, then I think it's okay.
Yes.
Rather than 0 wheals, maybe we should aim for good quality of life.
And when do you consider the tapering of the treatments? You mentioned about treat until complete control, until remission. But when we achieved a certain goal, do we need to taper the treatments? Because sometimes we give patients a lot of antihistamines, maybe 4-fold antihistamine or regular injections of omalizumab. So I think it's also another important question.
Yes, because spontaneous remission can happen, and we can't know when it happens. So we should sometimes start tapering the treatment, but when?
So there are 4 potential answers. The first one is when UAS7 0 for 4 weeks, or the second one is for 8 weeks. The third one is for 12 weeks, and the fourth one is more than 12 weeks. So please start to vote. What is your thought? And then Emeka will tell you her answer. Yeah, quite different. We have some more audience choose number A or number C, but quite different. Okay, you can continue to vote, but let me think about this question. How to taper medication and when do you taper the medication?
Yes.
How about your answer?
Yes, I think as we also saw in the beginning of the discussion, we were in the same idea that we should start tapering after complete control of 3 months.
Yes.
And the guideline also suggests us to start tapering down after we have the urticaria control test 16 for 3 months. We can start stepping down.
Yes.
We will come to this, but before that, I wanted to show clinical trial results of omalizumab that there is relapse when we stop treatment earlier. Okay. For example, if we stop omalizumab treatment in 24 weeks, we have a relapse rate of 43. Okay. And if we start in 48 weeks, that means almost 1 year, it's still the same. Mm-hmm. So the disease is not going anywhere in 1 year. So we as physicians tend to think that, okay, this is a 6 months treatment, or okay, this is a 1 year treatment, but it is not like that. We should always monitor our patients' disease activity, disease control, and act accordingly. If the disease is still there, it doesn't make sense to stop the treatment, because then the patients would suffer a lot, because the relapse rates are really very high with omalizumab.
So that means we don't stop it immediately. Once the disease is controlled, you must taper down rather than just stop it.
Yes.
Because the data show that if you stop it immediately after control, then the recurrence rate is quite high.
Yes.
Yeah.
Yes.
Okay, I understand.
That's the major message, and we should really first assess our patients with respect to their personal features. First, we have to assess their disease severity.
Yes.
We need to use the patient-reported outcome tools. Yes. Are you using any of the patient-reported outcome tools in your clinic?
Yeah.
Which ones do you prefer?
UCT and QCall are very important patient-reported outcomes we do use. Yeah.
Yes, urticaria control test is my favorite also, and it's also the guidelines' favorite tool, because the guidelines suggest us to manage the treatment according to urticaria control test results. If the urticaria control test is lower than 12, then that means that this patient is not controlled with this treatment. Then we need to step up this treatment. If the patient is taking standard dose antihistamines, then we need to up dose antihistamine treatment. Or if the patient is already on 4-fold antihistamines, then we need to step up to omalizumab treatment. UCT, but then when we have UCT between 12 and 15, then this means well controlled, and we can keep on this treatment. So the patient is happy and the physician is happy. And after a while, if we reach the UCT 16, that means fully controlled, complete controlled. But sometimes, urticaria is a fluctuating disorder.
Yes.
They reach UCT 16, but after 2 months, then all of a sudden they have a stress, they have an infection, and they have the UCT score 6.
Yeah,
Yes.
as well they have a COVID-19 vaccination.
COVID-19. The infection leads
Yeah.
to more exacerbation
Yes,
than the
yes.
vaccination. So it was the results we found in our studies. Infections, especially more than vaccinations, exacerbate urticaria so much. So that means that one UCT16 is not enough. We need to see that the patient is having UCT16 for at least 3 months before starting tapering down.
So that's the correct answer. Rather than using US7,
Yes.
it no matter 4 months, 4 weeks, 8 weeks, or 12 weeks. The correct answer is to use UCT16 for 3 months.
Yes. But again, UAS7, if they are happy with using
Yeah.
UAS7, it's okay. I
Yes.
think it's okay. If it's 0
Yeah.
for more than 12 weeks, we can also consider.
Okay.
Professor Chu. So, okay, then we need to start stepping down treatment. But the main question is here, and the guideline didn't give this answer to us. Do you know that? So I'm
Yes.
hoping that in this next guideline, which we are having on December, we will be discussing it in Berlin.
Yeah.
So I'm hoping that we may find some answers on how to step down the
Yes.
treatments. Because now, usually the physicians are stepping down according to their own practices. And we made a UCARE study. UCARE means, by the way, Urticaria Centers of Reference and Excellence. So now we are 174 centers around the world, and I'm hoping that we will soon have many centers in Taiwan, including yours, I'm hoping. So in these centers, we are doing a lot of projects, and one of these projects, we showed that UCARE physicians tend to discontinue urticaria treatments gradually. They discontinue gradually rather than abrupt withdrawal, as we have been discussing today with you. They don't really prefer to withdraw abruptly. So what can we do? Here is a roadmap that I tried to prepare for my colleagues here. So if the patient is on standard dose antihistamines, of course, there will be some time that this patient will get into spontaneous remission. So it is suggested that after 3 months of complete control, you can start stepping down antihistamine treatment. You can every other day you can give antihistamines every other day for 1 to 2 weeks and then stop the treatment. And if you see a relapse, then you can start again, and you can start stepping down after 3 to 6 months again. So every 3 months, you can try to step down antihistamine treatment. If the patient is on a higher than standard dose antihistamines, then we reduce the antihistamine dose every week, 1 tablet, or we can halve the dose every week. And then maybe when we have the 1 tablet, then we can again start to use it every other day for 1 to 2 weeks and stop the treatment. In case of relapse, we start again and do the same procedure again. So with omalizumab treatment, if we have 3 months of complete control again, then we can consider stepping down the treatment. If the patient is receiving antihistamine treatments, first we need to step down antihistamines, and later we step down omalizumab treatment. Omalizumab treatment is rather a step down by opening the intervals of injections rather than lowering the dose. So if the patient is receiving every 4 weeks, then we are opening the interval to 5 weeks, then to 6 weeks, 7 weeks, 8 weeks. And when the patient has 2 times 8-week intervals without any symptoms, then we can discontinue the treatment. And if the patient is on higher omalizumab doses, then we reduce the dose by 150 milligram every 1 to 3 months, and then we open the intervals of omalizumab treatment. If the patient is on cyclosporin treatment, we usually start stepping down after 6 months of maximum treatment, and we reduce the dose by 1 milligram kilogram every 2 weeks. So this is the scheme that I would suggest to my colleagues on stepping down the treatment of chronic spontaneous urticaria. So what do you think? Does it also resonate with your practice?
Yeah, I think it looks so delicate, and regarding different kind of treatments, different dosage of the same treatments. In my personal practice, I am a little bit more careful. So usually I step down slower. For example, I step down the antihistamine dosage or omalizumab dosage or for every 1 month. So every 4 weeks I change the dosage.
Okay.
Because we know that sometimes it just flare up or relapse after a quick step down. So in my daily practice, because usually the patient only come to the clinic every month or every 3 months, so I can use this strategy to explain to them.
Very wise and very smart. Thank you. Yes. So I think that's all for now that we wanted to give the messages. What are the messages we wanted to give today? Maybe we can make a short summary. That first is chronic urticaria remits one day.
Yes.
It will end one day. It's not a lifelong disease. The first message may be this.
Yeah.
And maybe patients with autoimmune and maybe atopic features may last longer compared to others. But in 5 years, almost half of them would achieve remission. And so we shouldn't stop the treatment abruptly.
Yes. We should continue the treatment until remission. And once they achieve the remission, we should taper in the dosage, the treatment slowly, and to see what happens and see the clinical response.
Yes, and monitor patients' disease control with urticaria control test.
Yeah, with the UCT test to see their patient-reported outcome and to decide our next step. Yeah.
Yes, I hope this was a useful conversation for our colleagues. So maybe we can get some questions.
Yes, thank you. Thank you very much for your wonderful talk. And we'll start to have some questions now because the audience, they are so happy to see your lecture and your introduction and also the explanation of these treatment guidelines and treatment strategies. So the first question would be, in the previous slide, is omalizumab over 300 milligram. It's also reimbursed in your country, in Germany or in Turkey, and how many patients in your experiment will need such intervention, in your experience?
Yes. So in Europe and in Turkey, omalizumab is reimbursed 300 milligrams every 4 weeks.
Okay.
So we don't have a problem with this, and the patient doesn't necessarily has to have an angioedema or BMI, high BMI or high total IgE. No, it's not a requirement. It's 300 milligrams every 4 weeks. So we start standardly with 300 milligrams, and the guideline also suggests to start with 300 milligrams. But I also observed in Korea that the reimbursement is only for 150 milligrams. So I think here it's a bit tricky that you need to start with 150 milligrams. Are you also starting with this dose?
Not necessary, because omalizumab is not reimbursed by our health insurance. So it depends on the patient's wish, and we can discuss with their goal, the immediate goal. But I usually treat patients with a fixed dose of 300 milligrams per month. But only if the patient, they argue about the price, the cost, and sometimes they are very slim. They are, in our Taiwanese girls, sometimes they have only 40 kilograms.
Yes.
They are very slim. So they ask about maybe we can have a lower dosage. In that case, I can use 150 milligrams and see the response. But personally, I prefer to have a fixed dose. Then you can make a decision very easily. Once they achieve UCT control 16 or UAS70 for 3 months, then we can quickly taper down.
Yes.
So that would be better. Otherwise, if you start with low dosage, if the next month they cannot reach complete control, then it's very difficult to make a decision. Maybe they are not responsive to omalizumab, or because just dosage is too low. It's very difficult to persuade them to increase the dosage once they fail the treatment. So my philosophy, usually I start with higher doses, standard dosage, and then taper down to make them happy.
Yes, because the world experience is that, and we know a lot of information from the previous experience about 300 milligrams.
Yes, exactly.
Yes.
And do you think that, is it possible that CS patient can be controlled and get to the long-term remission after omalizumab treatment?
Yes, we had this experience that 20% of the patients got into remission after omalizumab treatment. But we can never say if it was spontaneous remission or a remission caused by the treatment. So this is always the debate with chronic spontaneous urticaria, because they also claim that cyclosporine also puts the patients into remission, but we can never know this because it can also occur that it goes into spontaneous remission.
Yeah, but I would say that it's very possible that omalizumab can induce remission and take a longer time for long-term remission. In our AWARE study, either worldwide, in Europe, or in Asian countries, we see the same phenomenon. And omalizumab is the best one treatment options that can achieve the long-term remission comparing to the others.
Yes, it has a long life and it really lasts with long symptom control.
And the most important thing is that it's targeted to the disease pathogenesis itself. So it has a long-term immunomodulation to change the anti-FcεR1, the auto-antibody responses. I always say that it's just disarmed the mast cell, because it downregulates the receptor, the autoantigen itself. And then it can have an immunomodulating effect. Once you receive the long-term treatments, then the FcεR1 can downregulate. And once the longer time, the antibody response will be lower. I think that's the major reason why omalizumab can achieve a longer, much more percentage of a long-term remission than the other treatment, like antihistamine or cyclosporine.
Yes, I agree with you. And sometimes we can also note that some patients may take longer time to respond to omalizumab treatment. Yeah. There are slow responders and there are very quick responders. Yes. I'm sure you also observed some patients responding right away. Yes. At the other day they were free of urticaria, while others may take 24 weeks to respond. So we need to also tell this to the patients that it may take some time, and we shouldn't decide omalizumab treatment cessation before trying it 6 months.
Especially in patients with type 1 autoimmunity, usually they respond very quick. And with those with type 2B, because they are IgG against this receptor, the response will take longer until the receptor downregulated.
Yes, especially mast cell Fc epsilon receptor downregulation takes time.
And the next question will be, how do you think about the role of other DMARDs, CS DMARD, such as methotrexate, azathioprine, in the CSU treatments?
Yes. So as omalizumab is reimbursed in our countries, I feel really lucky. Before omalizumab, I have been using cyclosporine more than other DMARDs, because I usually find it very effective against chronic spontaneous urticaria. But now, after omalizumab treatment, and if cyclosporine is not an option, my first choice is Dapsone. And I find Dapsone also very useful. Sometimes in some patients I combined it with omalizumab treatment, because sometimes there is an infiltrate that you need to fight. Mast cells are the main cells, but there are also recruited cells that you need to clean the area. So if neutrophils are prominent in the infiltrate, then Dapsone really works well. If the eosinophils are dominant, it also really works well. So I have used hydroxychloroquine, I have used IVIG treatment. Sometimes I supplement vitamin D if it's low. Sometimes I give probiotics.
Yes.
Sometimes I used autologous serum treatment. We had a lot of experience in treating the patients when we couldn't give the usual guideline recommended treatments.
Yeah.
They can be tried, but of course the guideline treatments is the best.
Yes, exactly. Much more evidence-based and
Yes.
also
And
much more effective.
more effective, yes.
Yes. Yeah, I believe that in some cases with so-called neutrophilic urticaria or urticaria persistence in the dermatology field, sometimes we need using some DMARD, especially targeting to the neutrophilic infiltrations to have a better response than using omalizumab or antihistamines. Yeah. Okay.
Yes, sometimes they are needed, really very refractory cases.
Yes. And what kind of a treatment strategy for CSU has the highest rate of complete response? That's the key question. And also we have the key answer today. And the most good response to taper treatment medicine, the best treatment.
I think it's a combination of cyclosporine and omalizumab, I would say. Because you both target the T cells that, the T cells are consisting half of the infiltrate in chronic urticaria lesions. So it really makes sense to target them. Also, you are targeting with omalizumab the mast cells and the IgE.
Yes.
And when you give cyclosporine to them, I would say the most complete response is with this treatment, but it's not easy to implement, of course. We are usually getting a very good response with omalizumab treatment.
I just want to ask you this question. When you answer the questions about the higher dosage of omalizumab, because sometimes the patient cannot tolerate that for 600 milligrams per month, must pay by themselves on pocket. Sometimes very difficult to persuade them to accept that. And in this occasion, another choice is to combine the third-line treatment with the fourth-line treatment. That means the standard dose, fixed dose of omalizumab 300 milligrams per month, along with cyclosporine, maybe starting with low dose.
Yes.
Very effective.
Yes.
So
yes,
it's a good
I
strategy.
agree.
Yeah.
They can be combined, and it's a really good combination from my point of view.
But only
mechanics.
only if the refractory cases to a standard
Only,
line.
of course, of course.
Yes. So these are all very interesting questions and also very practical for our daily practice.
Yes.
And
thanks for the questions. Really.
Use serum markers to predict the omalizumab response.
Yes, of course. Very good question. And till now, the best marker is IgE, total IgE, serum total IgE. So it is said that if the levels is below 40, the response to omalizumab can be a bit slow or maybe no response. So when we see that there is low IgE levels in a patient, maybe we should tell them that it can be a bit slow, be patient, because these patients tend to have type 2B autoimmune urticaria.
Yes, exactly.
And there is another marker that is published in 2 studies, that it is the IgG-TPO / total IgE ratio.
Okay.
If it's very high, then there is a possibility that this patient has type 2B autoimmune CSU, and the response may be worse in omalizumab treatment.
Yeah. And do you use some other, such as some of the markers as a D-dimer or CRP or ESR?
Yes, they have been reported, but personally I don't use them. I check anti-TPO and total IgE as the guidelines suggest. CRP levels I don't really check, but it tends to be high in very active urticaria, really. But I really don't check if it's falling, or I don't.
I see.
D-dimer are you using? I don't use D-dimer also.
Not frequently, but in our data we also see a trend of D-dimer correlated with the disease severity.
Yes.
And once after the omalizumab treatment, the D-dimer became normalized. So that's our experience. Quite similar to those in Italy and in Japan.
Yes.
So maybe that's our future research about the biomarker for urticaria and treatment of biologics. And I think I asked you the similar question, but maybe the audience want to know this question. when you combine a four-fold antihistamines along with cyclosporine or along with omalizumab, and when they get remission, what kind of drug will you taper first?
Yes.
Antihistamine or omalizumab or
Of course,
cyclosporine?
the first antihistamine treatment.
Yes.
But at this point, I also want to emphasize or ask your experience, because in cyclosporine using patients, I don't really give 4 times of antihistamines,
Okay.
because generally it's not working in these patients, antihistamines. So
Okay.
they tend to have only 1 dose of antihistamines mainly,
Okay.
because cyclosporine also may have some interactions with the antihistamines.
dose.
It's a
Yeah.
high dose. So I usually tend not to give high dose antihistamines when I use cyclosporine, because they don't really work from my point of view in these patients. And yes, the answer is first antihistamine step down, and then omalizumab step down.
Okay.
And
That-
you, how do you do it?
It depends, because in Taiwan the situation is the omalizumab is not reimbursed. So the patient, once they have a financial economic concern, they always
Yes.
ask me to step down omalizumab first.
Ah, okay.
But only if
That's
those
another
patients,
experience.
yeah, but only
Of
if
course.
those patients, they are not so happy with taking so many pills. They are very busy, businessmen, students. They prefer to taper down the antihistamines. So we did have some experience. Those patients, they seldom take oral pills. They only receive a regular omalizumab injection, and they're quite happy with that. Because they can make their life more easily. They don't need to remember, I should take 2 tablets in the morning and 2 tablets in the evening. Sometimes for them, they're very difficult. So
Yes.
I do have such kind of experience that patient only taper down the antihistamine first, and then they only take omalizumab as the monotherapy for maintain their disease activity, and then finally they get remission without any recurrence.
Yes, very good. And this is right the point that the urticaria guidelines suggest, taking into patients' specific situations and considerations. I
Yes.
think it's very important to take into account their preferences.
Yes, yeah.
Yes.
Okay, I think we answered all the questions, and I think everybody get quite a lot of knowledge and also the concept of treating urticaria by Professor Kokatuk's talk. I think it's very useful and very practical.
And
thank
from
you.
you, of course, Professor Chu, you also shared a lot of experiences and we discussed together. I think it was really wonderful. I also learned from you, from your experience. As physicians, we must always discuss these topics so
Yes.
that we learn from each other. It's
Yes.
very valuable and
Yes.
important.
Yes. So thank you for joining us with this webinar. I hope all of you have a wonderful night and good evening.
Good evening. Thanks. Thanks
Bye-bye.
for having me. Bye-bye.